IGRA test is interferon gamma release assay test. It is released by the T cells in response to the two antigen, which is ESAT6 and CFP10 protein, where we draw the peripheral blood and the result of positive or negative comes in about 24 to 48 hours. Best thing about this is it is unaffected by the BCG vaccination status. CYTB is a new upcoming test which basically culminates or combines the MANTO technique and the antigens used in IGRA test, which is the ESAT6 and CFP10 protein. So it's an intradermal injection using the MANTO technique and a universal cutoff of 5 mm. Best part is not affected by BCG vaccination. Pathogenesis is nothing but suppose it is aerosol droplet goes into the lungs. Some people remain uninfected, like good healthcare workers who are good in their protein intake, and somebody might have a primary infection which can lead to primary disease, gone complex, gone focus. Some it will be becoming a latent infection. These two can cause lymphatic dissemination and hematogenous dissemination and reaching up to any part of the body. Coming on to management of EPTB, for the drug sensitive TB, it is the universal system, which is the intensive phase of 2 months and continuation phase of 4 months, which includes drug HRZE, which is 5, 10, 15, 25 mg per kg body dose. This red pack is what is the 4 FDC, and this green color is the 3 FDC or HRE, which is given by the dots at free of cost in India. So the treatment of duration of EPTB, very important, includes 2 months of HRZE, following which 4 months of HRE will vary, which is TB meningitis, it is 9 months, tuberculoma, it is 9 to 12 months, ocular, it is 6 to 9 months, ENT, remember otitis media, it is 9 months, lymphadenitis, plural, TB of the heart, abdominal TB, and GUTB is all 6 months. Spinal TB, another form of joint TB, it is 12 months, which is extending up to 18 months. Steroids in EPTB is steroids are usually not given in cases of pulmonary tuberculosis because otherwise it will suppress the immune system and increase the dividing tuberculosis bacilli. But some cases where the inflammation is more in the body rather than the bacilli, and when there is a risk of disability and mortality, steroids are used, which includes TB meningitis, dexamethasone of 0.3-0.4 mg per kg IV, TB pericarditis prednisolone, ocular TB, adrenal insufficiency or iris or paradoxical reaction. It has to be started and then gradually tapered up to and stopped in within 6 weeks. There are some gray areas in EPTB. One of the things is sequelae of EPTB. It actually mimics the signs and symptoms of active TB infection. So whether to stop the TB treatment or continue for another 3 months becomes a clinician's uh, call. It's like small volume fibrotic lymph nodes, neurological deficits, intestinal strictures leading to abdominal pain and vomiting, deformity and back pain in cases of spinal TB. There's something called as paradoxical and iris reaction. So paradoxical reaction is a deterioration of a TB. Suppose there was lymph node. So now after 3 months of treatment, first this lymph node decreases in size, then it increases in size, or some new lymph nodes are involved. This is what is called as a paradoxical reaction. It can be life-threatening and increase the disability. It accounts to about 25.4%, and it is because of excessive immune response to MTB antigen inhibition on an effective ATT. So if the infection is diagnosed and treated and ART is initiated, patient clinically deteriorates. Think in terms of unmasking iris only when you have excluded the other causes. If infection is diagnosed and treated and ART is initiated and there is clinical deterioration after first improvement and stabilization, it is called as paradoxical reaction. So remember, approach to treatment failure, non-TB etiology, paradoxical reaction. To rule out drug resistance, we can do that by first line or second line LPA. Now there are some special groups. Remember, in pregnant and breastfeeding, ATT should not be stopped. but streptomycin, prothionamide, ethionamide, and quinolones, which are usually used in MDR TB regimens, are contraindicated. Women who are on contraceptives should be given higher dose of estrogen because of rifampicin. And patients with acute hepatitis and if a non-life-threatening form of EPTB, then ATT should be deferred until liver function normalizes because ATTs are all hepatotoxic drug. But if EPTB is life-threatening in case of TB meningitis, ATT regimen should be started using some other group B or C or A agents. All EPTB patients should be offered HIV testing and vice versa. All HIV patients are prone for disseminated paradoxical high-risk reactions. Patients who have started on ATT, ART should be initiated within 2 weeks as soon as possible, irrespective of the CD4 counts. But in cases of TB meningitis, it can be initiated within 8 weeks to prevent iris. A TLD regimen, dolutegravir regimen is preferred. And remember, if you have initiated on ART and you get TB within 6 months, it is not because of treatment failure, but after 6 months, it might be because of ART failure. Then we should rely on CD4 count and viral load.